Okay, so we're going to talk about ventilator medications next. And before we get started, the components of sedation, which is what most of these medications are, is sedation itself, which means to me that a patient is not flopping around like a fish, and it allows you to take care of them. Some people would interpret it to mean that a patient has loss of consciousness, but in there is amnesia, which means that they don't remember what happened to them while they were sedated, and analgesia, or pain relief, and then anxiolysis, which is to say that they are not worried about what's happening. So all of those are components of sedation, and each of these agents have different degrees of taking care of each of those separate components of sedation. So these are the medications. Most of you are familiar with propofol, and we're very familiar with ketamine. Take care of a lot of patients who are on both midazolam and fentanyl. So the two that we're less familiar with on this list are dexmedetomidine and cisatracurium. Dexmedetomidine is kind of the new darling of the sedative world, and it's used very often in the intensive care unit and in the operating room because it does a good job and tends not to make people terribly hypotensive. Cisatracurium we'll talk about last, but it's a paralytic agent, so it doesn't provide any of those things that we just mentioned above: sedation, amnesia, analgesia, and taking care of anxiety. So dexmedetomidine is also called Precedex, and one overriding theme for almost all of these sedatives is that they can cause hypotension. And dexmedetomidine can also cause bradycardia, but that's more frequently seen with a bolus of the medication. And if you remember the initial slide, there you go, in case you forgot. It's called ventilator meds for a reason. All of these patients should be paralyzed, and dexmedetomidine can cause respiratory depression in about 37% of people. And we don't want to be giving something in the back of the ambulance that's going to make them apneic. I mean, we could be prepared for that, but better yet, let's have them intubated first, right? So we will titrate this medication if necessary to balance sedation and blood pressure. That also is an overriding theme. And you can always consider giving fluids also for somebody who is inadequately sedated but has kind of a soft blood pressure, and you're going to have to go up on the sedative. Propofol is the next agent. It's called Diprivan as well, and it's very difficult to use in the ER now because Michael Jackson died of an overdose related to its use. So propofol is a sedative, but it does nothing for pain. So that's for us, it really doesn't matter because primarily we're going to be using it to transport patients who are intubated. But, for those of you who work in the ER, somebody with a fracture, for instance, who has it reduced and they're sedated with propofol and then their fracture's reduced, that's not at all adequate pain control for the patient, and they're going to have blood pressure and heart rate responses to fracture reduction during the procedure. And they should obviously get analgesics like fentanyl or morphine or something like that, either before or during the procedure. So the cool thing about propofol is that it only lasts about anywhere between 3 and 10 minutes after a bolus of propofol. So it's not a light switch, but it's very rapidly on and off, and that's part of the beauty of it. I mean, you can give somebody propofol for a procedure, and they go home an hour later roughly. But again, that's not the case. We'll be using this medication to keep people comfortable during transport while they're intubated. The main problem with propofol infusions is that it causes hypotension, and again, for this, you have to either titrate the infusion down or give them fluids and see if they respond that way. 26% hypotension during an infusion is what's noted in the literature, but in my experience, it approaches 100%. So it is a great amnestic. In other words, people will not remember the things that are occurring around them when they're on propofol. All right, here is the ER darling, ketamine, and that's because those things that we talked about earlier, inducing loss of consciousness and amnesia and analgesia, ketamine addresses all of those things. It has an onset of about 3 to 4 minutes when administered intramuscularly, and I'm covering some of these things. I mean, certainly this little mini presentation has to do with transfer patients and transfer meds, but we are also using this in the field, so this is handy information to know. When you give it IV, it's almost immediate effect, I would say within a minute. So the IV duration of effect is about 20 minutes compared to intramuscular duration about 40 minutes. And that's going to change with the patient and with their body fat and then like how long you're using these drugs for. But again, it's absolutely fantastic, assuming it's an adequately dosed, but sedative and pain reliever and amnestic agent. They won't remember anything while still maintaining hemodynamic stability. So there is one problem with ketamine, and that is that it has a fairly common incidence of emergence phenomenon, and specifically people get kind of delirious when they're emerging from ketamine. But I like to say, and especially for us transporting patients, not our problem. So that's something that whoever takes them off of the drip will have to deal with it. Just so you know, too, ketamine was previously contraindicated for patients with a head injury because it was thought to elevate intracranial pressure, and now it's thought to be protective during head injuries. It was also contraindicated where there might be high intraocular pressure, but that has been debunked as well. So when we transport patients on a ketamine drip, we're primarily going to titrate up only and not down because there would just be no reason really. There's no adverse reaction to ketamine that would require decreasing the infusion dose. We're fairly familiar with midazolam, also called Versed. It is in a class called benzodiazepines, and it is similar in structure and effect to things like Valium, Ativan, Xanax, Klonopin, etc. All the things our patients like to overdose on. So midazolam is a sedative. It gets rid of anxiety. It's an anxiolytic, they call it again. And it also induces memory loss. It does not address pain. Midazolam itself lasts about 4 hours. And interestingly, I saw, just the amnestic part. I saw a kid who'd been tased multiple times, and he was very rambunctious in the ER. We had to put a Foley catheter in him and stuff. And he was pissed, and he made some comments to me and the police and the nurses and everything. And he had gotten a lot of Versed in the ER though, so we could do what we needed to get done to check him out. This guy came back the next day, and I was like, "Oh man, he's gonna give me a hard time." But he didn't even remember. He didn't remember me, and he didn't even remember having been there the day before. So that's a pretty cool example of the type of amnesia that these medicines can give you. So one of the downfalls, of course, is respiratory depression. We don't really care if they're on a ventilator. Hypotension is a lot less common with Versed unless it's combined with opiates like fentanyl. Speaking of which, so typically for an intubated patient, Versed is combined with fentanyl to give not only the sedative and the anxiolysis, but to give pain control as well. So these medicines kind of work well together, but again, when they're combined, more often lead to hypotension than either agent would alone. Let's see. So fentanyl lasts about 1 to 2 hours after an IV injection, And alone, it's really, really hemodynamically stable. It shouldn't do much to the blood pressure. Unlike morphine, it doesn't cause histamine release, so you don't see flushing with it. And that, I think, too, that's why you don't get that hypotension with administration. All right, cisatracurium is not a sedative at all. It doesn't induce amnesia. It doesn't give pain control or anxiolysis. It is a paralytic agent. It's actually used like never in the ER, and it won't be used by us in the field either. It is occasionally used in really sick patients, mainly to take out their work of breathing. If you've got somebody who is just maxed out trying to recover from an illness, taking out their breathing really helps a lot, just to decrease their metabolic load, so to speak. So anyway, this agent, cisatracurium, which is also called Nimbex, is a paralytic that's used only on intubated patients. It lasts about an hour. It's pretty well tolerated, but because it's not a sedative, we have to make sure that if someone's on this medication, that they're also on a sedative. You would never, ever, ever use this medication alone, because that's called torture. Let's see. For each and every one of these medications, I would suggest doing fairly frequent blood pressure and pulse checks. These patients should all be monitored, but I guess the only addition to that is just frequent blood pressure checks. For cisatracurium specifically, there's really no need for titration. I would just leave it alone unless they're moving around. You can call online control to adjust the rate of infusion. Thank you.